Good after lunch. Let me take this opportunity to introduce Celestina and Matthew, who are going to be the leaders from the SME side. Thank you.
All right, thank you. I hope we had good lunch. Nobody's answering. Do we need to do some work, some exercises after lunch exercise? Okay, so my name is Celestina I'm part of the external assessment team, and I'll be leading on this. I have my colleague.
A very good afternoon, everyone. Welcome back from lunch. My name is Matthew Tut, and I work with Africa CDC. I will be co-leading this technical area. Thank you. You're good to go? Dr. Susan, please.
Thank you so much. Good afternoon. This is the National Laboratory System, and I'll request my colleagues to come up, Dr. Tim and Akrut. Please kindly come up to the podium. Five minutes. Lab systems is big. Okay. Dr. Tim and Akrut. So I'm presenting the Uganda National Lab Systems. And those are the abbreviations that are in our document. And as a background, IHR requires a national laboratory system able to support the diagnostic testing with the target of having surveillance with a national laboratory system with effective modern point of care and laboratory-based diagnostics. And this is measured by having a national laboratory system that is across the One Health sectors with both capacity for on-site diagnostics, but also sample referral systems. And also measured by having an existence of the national quality laboratory standards and systems for licensing laboratories. And these are the different stakeholders that we are part of the assessment. Just a background of giving you how our national laboratory setup is in One Health approach. We have the human health laboratories that deal with human health affairs. We have water and environment laboratories that deal with water and environment, mainly around soil and air quality. We have animal health laboratories and laboratories in the Uganda Wildlife Authority. These deal mainly around livestock and wildlife health affairs. And these are all this is our national laboratory setup in our One Health approach. And we mainly look at disease diagnosis for patient care and prognosis, but also in terms of public health, disease surveillance and outbreak investigations and response. We also look at food, the quality of the standards of the lab, the carry out research, we train, and also we do forensics. This is the laboratory network. It's in a tiered approach, having the national reference laboratories up to the lowest level of health labs, up to the lowest level of laboratories. In the human health sector, we move up to Health Center 3, but as we speak, we've also moved into the community, and we have 6 national reference labs with 16 regional hospital labs, 53 general hospitals, 195 health centers, and over 1,200 health center 3s with a total of public sector labs of around 1,500. But in the animal health sector side, we have 2 national reference labs, 8 regional labs, and 17 district labs. And at the same time, on the water side, we have 2 national reference labs and 4 regional labs. And all these help us to access health and laboratory services for all our 45 Ugandans. So one of our indicator of specimen referral and sample transport system, the strength is that we have a nationwide model sample and results transportation system that is in place. And this is in the Ministry of Health, that is able to transport all samples, all sample types from human, animal, and environment sectors. And the best practice here is that we are using the hub system, where we've developed 100 hubs that are that are well equipped with human resource equipment, able to carry out the different tests at the level of care. And we have a structured routing of these samples facilitated by a fleet of motorcycles and vehicles. And these cover the whole national geographical area. Then we also have guidelines for sample transportation in the human sector. And the ones for the MAIF side, the guidelines are still in draft. And these guidelines for the human sector have been rolled out into a hub and spoke approach. And we regularly carry out performance review of these guidelines to see if they ensure adaptability and they are achieving what they're supposed to achieve. We also have existence of sample chain of custody through electronic sample tracking across the referral network. The areas we need to strengthen under sample referral transport system, we need to strengthen Government of Uganda funding and ownership, because we've noted that the system is largely funded and we have limited funding that is directly coming from Government of Uganda. And the resources are still limited because we have the different MDAs with a lot of interest to transport their samples through the system, but the operational resources are limited because they've not yet put in any resources to do that. So there's limited resources to strengthen capacity in MAIF, UA, and to satisfy the multi-sectoral transportation needs. In terms of coordination, we still have suboptimal coordination amongst and within sectors. And we've also noted specimen overload that is not matching the available resources that we have. We tend to have occasional inefficiencies that affect transport turnaround time and the supplies together with the stockouts, especially if it involves transporting samples across the different sector. So for specimen referral and transport system, we scored ourselves at level 4 because we thought we have the referral and transport of specimen is organized systematically for diagnosis and or confirmation of other priority diseases at the different levels of care. The second indicator is about the quality of the lab systems. The strength that we have is we have over 68 laboratories accredited to various ISO standards in the country. And the best practice is that we have available and adopted the National Laboratory Quality Management System program that is cutting across all the sectors. We've engaged MAIF and bringing UA on board, and we are utilizing the acceptable international framework. We are also implementing QMS across the sectors with experience of using frameworks like SLIPTA, SLAMTA, and currently ISOs to which different sectors are preparing labs towards accreditation. So we've had the labs, both health and animal side, participate in EQAs. We've built capacity in country to prepare EQA panels, and we've also built a pool of mentors and trainers over time to use both the national and international training to support all the sectors. We also noted that there's a buy-in from of all sectors. Quality needs a lot of management buy-in, and we've noted that commissioners from the different directorates of the different MDAs are part of these activities, and regular accreditation of laboratories and systemic capacity building. When we are preparing labs for accreditation, the commissioners are part of this. So we've noted buy-in from the management. The areas that we need to support, to strengthen, is still resources. We have varying levels of access to resources among sectors. Some sectors really have low resources. Others have some resources. For example, health, we are using the resources in health to support the other MDAs in terms of improving their quality. The program is really costly. and we over-rely on international agencies for certification and accreditation. For example, accrediting a lab just needs $10,000 to be able to do this. We also have issues of reporting systems. We have not yet fully interoperably done this across sectors, and the animal health, water, and environment are at varied levels of LQMS implementation. For accreditation body, we have not yet put it, it's not yet functional, but we're on the roadmap to form our own UGANAS, Uganda National Accreditation Body. So we shall be able to soon, maybe in the next assessment, we'll have our own accreditation body. Proficiency panel production, we are currently some labs are currently producing panels for the different labs, but this is being done in a siloed approach. So we scored ourselves at level 3 because we have the national quality standards that have been developed and implemented at the national level, and activities including licensing laboratories in conformity with the national quality standards. At the national level, this is being done. That's why we scored ourselves at level 3. We've not yet moved everywhere. The other one is about the testing capacity modalities. Strength, we have existing collaboration amongst MDS partners, universities in our One Health approach. In this way, we are sharing technologies and capacities for testing across sectors, and we have standard operating procedures in place, and we have also accredited some labs in these different sectors. We also have reliable sources of qualified workforce with place to conduct the refresher trainings, for example, in biosafety, good lab practice, training on any new technology that comes on across. And this is because we have universities and tertiary institutions that churn out qualified persons every year, and we have research institutions and training institutions that support them. Then the procurement process has been modified with framework contracts, and there is ease of acquiring supplies, and this is because we have we've put up pre-qualified suppliers with availability to preposition supplies in case we really have the need, and we know the acceptable lead times. We also have presence of in-country equipment calibration capacity to be able to support these laboratories. We have a certified National Equipment Calibration Center, and this helps us in calibrating the different equipment across the sectors. And the country has capacity for conducting high-level and complex techniques like sequencing using the next generation platforms. And the best practice, that capacity has been developed on genomic sequencing and bioinformatics at the different national reference laboratories. The areas we need to strengthen: MDS and collaborative agreements. We really lack institutional level binding frameworks between the MDS and operational guidelines to support this. Also, MOUs with manufacturers. The procurement process is limited and so not efficient in supporting emergency supplies and evolving technology. This, we noticed it a lot in COVID and Ebola. Then the staff turnover. We have a lot of staff turnover of our experienced staff and are being taken away. Then the EQA programs. For some of our priority diseases, we don't have EQA programs. And also fast-tracking accreditation of EQA producing labs in the health sector, because not all centers are currently producing materials in line that are, not all centers that are producing EQA materials are accredited. We also need more capacity building in bioinformatic genetic analysis, and this is because we don't have inter and intra-sectoral coordination mechanism for lab experts to cross over and exchange ideas. So testing capacity modalities, we scored ourselves at 4 because we have a lab system that can perform nucleic acid amplification testing, bacterial culture with AMR sensitivity testing, with quality assurance processes in place, and has some basic sequencing capacity, and country has ability to test for all its endemic diseases and its priority diseases using the laboratory network we have. This is the last one. Sorry, the lab was quite wide. Effective national diagnostic network. The strength is that we have established and structured service delivery, as I showed you, in a tiered manner, and they are supported by available on-site testing capacities in terms of human resource, equipment, QMS, with a strong sample transportation system. And these mechanisms have enabled us to reach all the testing labs and the samples get tested. We also have availability of strategic frameworks with, for example, we have guidelines that guide POC use. We have test menu to know at what level should the different tests be done. And we have a draft multi-sectoral national laboratory for priority zoonotic diseases. And in here, the implementation of the National Diagnostic Network is approved on this framework I've mentioned, and awareness of these documents has been made through the different dissemination mechanisms. We've had trainings and shared the printed copies, and some already in the websites of the different MDAs. The country has also access to a wide range of POC testing platforms, and as I already said, that we've also moved into the community. For example, when we had COVID, we had to go to the community to sensitize, and people got tested from the community level. So we've integrated a number of diseases on that sample platform, eliminating acquisition of new platforms. For example, GeneXpert for TB, COVID, and VHF. So we are using multi-disease testing on the different platforms that we have. On the side of MAIF, it's increasing recruiting of the laboratory professionals for regional and district laboratories, and also the presence of laboratories at all levels across sectors that provide a range of testing modalities from POC to family-based to specialized testing, for example, PCR and genomic sequencing. So the challenges is the tier testing guidelines. The national tier testing guidelines are not approved across for the human health. They are there, but across the MDS, they are not there. Outbreak response supplies is a big issue, especially when we have outbreaks. We do not quickly get the supplies as we need. And for the side of NADEC, the budget for NADEC, the vet lab services have no budget for lab operations and supplies. It's just part of the departmental vote that has different range of priorities. And the resources, also MAIF vet labs at regional level, are not fully recognized and funded by the local government. So in effective national diagnostic network, we scored 4 because we have a tier specific diagnostic testing strategy that is implemented at the national level. So in summary, our priority areas for action is to fast track accreditation of our national reference labs and selected regional labs, especially in our sister agencies that don't have these accreditations, leveraging on the existing systems to strengthen and create systematic and organized specimen referral and transport systems for diagnostics and confirmation of all priority diseases in a One Health manner, and also develop a national laboratory interoperable data sharing and reporting system between the different MDAs, and implement a system for timely procurement and distribution of essential and emergency lab reagents during emergencies, and create a platform for community and multi-sectoral and interdisciplinary knowledge exchange, especially in this new era of evolving technologies. So if you look at our scores, this is how we scored ourselves. And I think there's improvement from 2017. 1, 2, 3, we scored 4. And the fourth one for quality systems, we scored 3. These are the reference documents that we used. And this is the team that was part of this. With that, thank you so much for listening. Thank you.
Thank you very much, country team, for your wonderful presentation, and thank you for stating everything as clearly and as explicitly as possible. I think we'll just go straight into the meat of the matter. We'll go straight to the scores. Can somebody project for me, please? Do we? Okay. Okay. Okay, while we're waiting, in the interest of time, I think we'll just go ahead. For indicator 1, you scored yourselves 4. Referral and transport of specimen is organized systematically for diagnosis and or confirmation of all priority diseases at all levels. I think we agree with you. So we maintain the score of 4. However, a priority action based off of your challenges, the issue around funding, national funding. I don't see anything in your priority actions that speaks to how the government intends to ensure that there's government funding to sustain those systems. Because essentially, if you're going to maintain the score of 4, demonstrating that capacity, there needs to be a sustainable system for this. So we might have to revise your priority actions to include an action for that. Toots, do you have any comments?
Yeah, no, thank you very much, Dr. Susan and the team for the great work. And I concur with what my colleague just mentioned. But looking also at what you just presented, you talked about some documents are still in a draft form that need to reworked on. And I think it's something that we also need to see how we can improve on that. The issue of funding and the coordination among different sectors. And I think when we look at the lab system in general, you can be doing very well at the human side, but the other aspect might pull you down. You have the urge of going to 4 or 5, but we also need to look at the other sectors. What is the other sector doing? And are we genuine in saying, for example, we are at 4, or we can try to bring all the label together so that we move in a synchronized manner? So those are the things that we might need to look at, and we allow you to judge yourself. We are not judging, we are just trying to look at the other components so that we can move in a systematic manner. Back to you, Sarsi.
External team, before we leave this indicator, do you have any comments? Okay.
That was for indicator.
Okay, thank you very much.
We are protesting against
The indicator specimen referral and transport system. 4 is saying referral and transport of specimen is organized systematically. That's the word that we need to take note of, for diagnostics and or confirmation of all priority diseases at all levels. That's a bit very strong. That's a very efficient, effective system. So we need to look at it, because all levels include from household to community to intermediate to everywhere. So we need to rethink and relook at our system. Are we at that exactly, or there's still some things that we need to do? If there are still some little gaps, then we'll rather go a bit down so that it gives us room to improve to 4.
And sometimes memory can be very short. So I will request whoever is projecting the slides, if you can go to the slide that summarizes the laboratories by sector and by level. Godwin, we sound you out. Again, it was among the first slides. It's slide 5. Yes. So for animal health, in a country of 48 million people, we have 17 district laboratories. I don't know how many districts the country has, I can't quite recall. 146. We have 8 regional laboratories, and we have 2 national reference laboratories. Mine is a humble request that you walk us through how 17 laboratories cover the expansive 146 districts, acknowledging the diversity of Uganda and the fact that almost every community in this country keeps animals, and also for water and environment, but that I will leave it aside. But also at the same time, let's also remember about the veterinary side. If you could just walk us through that convincingly on how these 17 laboratories are able to cover the expanse of the country.
Yeah, and in addition to the team lead's comments, I think the projection says most of the regional labs in the animal health sector are not recognized. That means they're just somewhere. So how does that all add up? How do they support one another?
Just to add to what you just said about the accreditation of these laboratories, one thing is for you to have laboratories in place. Are they up to standard in terms of their performance? Thank you. Yes, I was asking about the accreditation of these laboratories in terms of their, the standard, the EQA system in place for them to actually be able to confirm some of the pathogens. So, thank you.
So if the country team could respond to those, and then, so we're done with this indicator before we move to the next.
Thank you so much. Somewhere just comments on funding, which was already raised, and we need to really put it into our action areas and coordination, because those are the challenges that were indicated. I'll ask my colleagues from JEE Fund and UA to respond to how the network, the referral system sends samples to the few labs they have. Yes, Dr. Tim, and then.
Good afternoon. Yeah, thank you so much for the concern. I'll not repeat about the funding. I think it's so glaring that we can see that we need actually sustainability, which I agree strongly with that. I think the other concern raised was on, I think that most of the documents are still in draft, which I say, yeah, that is a gap that we have. But we are also having the final, or maybe I call them zero draft, just left with getting the concerned officers to ensure that these are signed and made available to the stakeholders. Then, in terms of there are still gaps in a need. Yeah, I think my brother there said convincingly to appraise the labs that those are really strong. I don't know whether I will get convinced at the end. Yeah. So for the animal health sector, we have few labs, which is true, as we've seen there. But what I would like to outline is that there was a miscapturing of the district labs. We have 32 labs instead of 17. I would like to clarify that, and I really apologize for the 17. But as we also see the distribution of 32 labs in respect to 148 districts now. Yes, we see that there is still need, and in addition, we've realized also there's a lot of needs at the borders. So we also have the border labs at the checkpoints, because we have those labs that captures issues of food safety and quality assurance. So those ones we are also under construction. So I agree with the observation that the labs are not adequate, but however, we are also making significant progress towards improving them. So instead of 17, we have 32 labs. Yeah, I think that's what I can say for now. Thank you.
Do you want to say something too?
Yeah, thank you very much, colleagues. So, given all these inputs from different colleagues, and if we are to compare, for example, the animal health and the human health, are we convincing ourselves that we are at level 4, or we need to look at our scoring at this level? The country team.
I thought we're dealing with a specimen referral and transport system, and that's why it was set up to transfer samples to where there is testing. And the network is nationally distributed. So wherever there are samples, they can be taken to. It doesn't mean that you must have presence of that lab in that area to be able to to be able to test. For example, on the national side, we transfer samples from Karamoja to the center to be tested. So the issue is about the robustness of the sample transport to link. Maybe that's what we should be able to look at. That's what I would say.
Yes, as Dr. Chikanga is coming in, does that also apply for the animal side, the same referral system, or is only at the human side? Dr. Chikanga.
Yeah.
I think before maybe he comes in, I think when I presented that it's an integrated sample transportation system that does for animal health, ua, and environment. So it captures wherever there's a sample, we set up mechanisms of how these samples can be taken to the nearest testing lab. Or if no nearest testing lab, for example, the animal side, they are all driven to the NADEC lab. So I think the issue was around the sample referral before we go maybe to the testing capacity and the testing. This indicator was around that. Stand to be corrected.
If you were in Zambia, I would have called you Nanga, because you read my mind, sort of. And Nanga can be a praise, but it can also be derogatory. Now, that's what I wanted to find out, because we have opportunities for piggybacking, that's the word, on an established system. But I just wanted to challenge us to be most sincere over this. And luckily for you, we do not reside around, and we do not know the intricacies of the system. And also lucky for the system, even when we go out to the field on Thursday, we may not have the opportunity to visit the buffaloes up west and confirm that this exists, because we shall hang around Entebbe and here. And so the levels that we are going to visit and communities are around here where there aren't many animals to talk about. But I just wanted us to do, to search our hearts and ask ourselves if there were events, because there are two keywords in that level 4, all levels, that means up to community level, peripheral level, and the other keyword is all priority diseases or pathogens. And so if we have this conviction that it works for all priority diseases, number 1, and number 2, at all levels up to community, and specifically for animal health, then we grant you. But remember, we shall be doing the country a disservice to grant you if it's not true. So guilt conscience.
Okay, thank you very much. Yeah, because 4 is a robust system. So our system robust. Robust is robust. It means it's working without hiccups anywhere. 100% efficient. Then 5, we are talking about sustainability. We don't even go there. So we look at the robustness, if there's a word like that, of the system. But if it still has some things that can push it to robust, we would rather go a step down and then improve. Because here we are looking at One Health, looking at the animal. Think about the animal. Don't just focus on the human. Think about the environment. All priority diseases that you have on your list, at all the levels, including those that are residing on the mountains, on top and everywhere, if there are mountains everywhere. That's how we need to look at it. I'll be comfortable with the 3.
Thank you so much. 3 reads, referral and transport of specimens is organized for diagnostics or confirmation of most priority diseases from intermediate to national. That will also be a disservice because we don't stop at intermediate. It really goes down. So I have colleagues in the house.
I think maybe the chair.
It's okay, we can have.
Okay.
I think we've made significant strides above 3, But honestly, we are not at 4, no? Can we put 3 point something there?
Chair, I'm sorry.
There's no 3 point something. And that's where the priority actions really come in. And, colleagues, I also want us to look at this, a bit more, I don't want to use the word, a bit more objectively. Um, there are other indicators for lab that will speak to other aspects of the lab systems. But this indicator is specifically for specimen referral and transport systems. Okay? So what I will do is, if there are any other questions that we feel have not been answered, we'll take this to the parking lot. We'll leave it at 4 for now with an asterisk and request for extra documentation in a side meeting from the country team. We will finalize on that later so we can move ahead. Are we okay? We're still on indicator 1. Lab, we have 3 more. Apologies. We'll have to move ahead, please. So we go on to indicator 2, which is laboratory quality system. You've scored yourselves a 3. Before I will give my thoughts on this, I would like one of you to walk us through the mechanism for licensing of labs in Uganda. Your presentation doesn't mention anything around that. There are some concerns around accreditation, which I will come to. But on the issue of licensing, because indicator 3 says, aside from national quality standards being developed and implemented at national level, there's also that second part that deals with the licensing of labs in conformity with national quality standards. So the things I would like you to answer: do you have a national body that is responsible with appropriate legislation for licensing of labs in Uganda in conformity with quality standards, first of all?
No, but as when we're developing the licensing guidelines, on the human health side, we have a body that licenses and regulates the laboratories. But in discussion with our colleagues, for example, who has said that they do not have, and MAIF, so we're like, can we leverage as we decide which body will do that, but we don't have a national body that licenses laboratories in the One Health approach. It's mainly like the licensing is on the human health side, but we have the standards that we have developed, and the standards include that the other MDAs will leverage on the human health side to be able to do that. So activities including licensing laboratories in conformity with national quality standard is there, but on the human health side. But our guidelines say that they can leverage on the human health side as they license.
So given that, would you be comfortable to stay on 3?
National quality standards have been developed and implemented at national level. Activities including licensing laboratories in conformity with national quality standards. The labs that are licensed, they follow this, but not all laboratories are licensed.
But there's no framework for licensing. So how are the labs?
In a One Health approach, yes.
So 2 things. The framework for licensing of the labs. You said there's no legal backing. Which agency is responsible for that? Or at what level does this licensing take place? Okay, can you walk us through? Just give me, so for instance now, I'm a private sector person. I want to set up a lab, say in Entebbe. How would I do? Who would I go to?
Lab is dealing with, if it's human health, you apply to get your lab licensed by the regulatory body, that's Allied Health and Uganda Medical Dental Practitioners Council. Then you go through the processes. They have all these guidelines that they'll use to license your lab, including the new licensing guidelines. We included issues of conforming to quality standards. But on the side of the animal and wildlife, as I said, when we were developing the guidelines, since they didn't have a body, we thought that they can leverage on the side of, we work together and leverage on the side of the human health side, because that was a very big gray area when we're trying to get a one body that licenses labs across all sectors.
Yeah, I totally understand that, and it's okay if you want to, work within the scope of One Health, work together. But is there a document that speaks to this? Okay. Do you want to make a contribution? Okay.
Yeah, for the animal health side, we have the Uganda Veterinary Board, and we also have a guideline, but as already recognized, is still a draft because we realized that was a gap. So there is also a lot of steps that have been undertaken towards that direction. Thank you.
Toots, before we finalize on this.
Yes, as the rest of the colleagues are also coming in, looking at this aspect, and the way Dr. Susan mentioned, from the human side, it seemed like we are doing quite good. But looking also at the other aspect, the animal side, most of the document is still in the draft form. And remember, in this area, we are more looking at the national capacities that are supposed to do these activities, licensing, accreditations, and the national EQA that we need to have internally. But from the presentation, it seemed like we are depending solely on the external accreditations, the ISO, and so on and so forth. And Dr. Susan mentioned that processes are undergoing to establish a national accreditation agency that is not yet put in place. So if we are to look in this aspect, are we comfortable with saying we are in 3, or we can look at it?
As she comes in, if you go to 2, we are tied by what was put here. If we're left to put ourselves where we belong, we may be rude, because 2 says national quality standards have been developed but not implemented, which is also not true. So where do we belong? So that's where we need to agree, because you clearly put the different indicators. So that's why I'm looking at it in that line.
Comment from before we finalize on this. We'll leave the country colleagues for now. Hold on, please. Okay.
Yes, you have a mic.
You have a mic in front of you. Can you project? Okay, while we're okay. Okay.
Yeah, yes, I want to say a few things which seems very, very, very important and critical. And when you just assessing the laboratory, AMR, and also zoonotic disease, we need to evaluate the animal health sector and also the public health sector differently. And we need to accept the list score among the animal health and the public health sector. So, and I want to hear from animal health sector in this regard, because there are laboratory capacities we know from the public health sector, but the issue is the animal health sector. So in this regard, we need, as per the standard, we need to hear from the animal health sector on those indicators.
Okay. 30 seconds.
Thank you so much. I'm supplementing from the side of animal health. We have the Veterinary Practitioners Bill that has been passed by Parliament. It's currently before the President, awaiting his assent. And that bill is establishing the Veterinary Practitioners Council. And that council is going to be regulating the licensing of the veterinary labs, the labs in animal health and wildlife. So it's just waiting assent by the President, which we hope to happen very soon. And that council will be regulating those labs, things to do with licensing, the practitioners in the labs. Thank you.
Anima, yes. 1 minute and then we'll finalize on this.
All right, thank you so much. We realized that from the last time when our score was very low, it was because of the animal health side. And we have made strides as technical people. I work in the lab. We asked ourselves in the animal health sector, what can we do? Where can we start from? And therefore, that's why we decided to select an ISO standard to follow and implement instead of lagging behind, and probably having the same score as the last. Thank you.
Thank you for your contributions. My co-lead and I have, put heads together, and I think we're comfortable with leaving you at 3 for the following reasons, and this is also for my colleagues on the external team. It says national quality standards have been developed and implemented at national level. I think for both the human and animal, they have been able to demonstrate some implementation at national level. That score does not speak about subnational or intermediate level. And then the other part, activities includes licensing labs in conformity with national quality standards. At this stage, at this scoring, it is not mandatory. So if the country can show evidence in both sectors or in the 3 sectors that there is some form of licensing going on in conformity, and I think they have given some explanations to that. It may not necessarily be, what's the word that I want to use now? Yes, for lack of a better way to put it, there is evidence that the activities going on in conformity with quality standards. However, the priority actions are what really are important at this point. The issues around legislating, the Veterinary Council, for human health as well, and the accreditation policy for EQA. You will not be able to move beyond the score if you don't put some of these actions in place. So that's that for indicator 2 for lab. Are we okay? Okay. So we move on to 3. Lab testing capacity modalities. You scored yourselves a 4. And it says lab system can perform nucleic acid amplification testing, bacterial culture with antimicrobial sensitivity testing with quality assurance process in place, and has some basic sequencing capacity, and country has ability to test for all its endemic diseases and its priority diseases. My question, all?
Yes.
This is where we're going to have a bit of, okay.
All
okay.
endemic diseases.
And priority.
Diseases
with evidence of EQA in place for all of them.
Yes.
Hold on.
Yes.
In both the human, animal, and environmental sectors.
Yes.
I will need evidence. So, I will put this in the parking lot, de facto, because I don't think we're going to agree at this point. So we'll put this in the parking lot and we will go to a side and we will require evidence for all of your endemic and priority diseases with evidence of EQA for all of them in both the human, animal, and environmental sectors. That's the only way we can agree on this score.
That's
Okay.
You've added with all EQA, which is not part of because we know EQA, if we do internal controls, because here there's no all with EQA, unless when that's an added whatever here.
Uganda, we will still put this in the parking lot. We will take this to the side room or a side meeting and look at the documentation for this. Okay. So we move on. And also looking at some of your challenges as well for priority actions. But we'll take that in the interest of time. We've agreed. Are we agreed that we'll go to a side meeting and we'll come back and tell the House what we have agreed? Okay. Because I don't see us agreeing here. The final effective national diagnostic network. You're giving yourself a score of 4. Tier-specific diagnostic testing strategies are being implemented at the national level. My first question, your tiered testing guidelines. So if your guidelines have not been approved, what is the framework or the document on which your tiered testing strategies are being implemented? National, subnational, national, any level.
Yes, the tiered network for the One Health approach, I indicated that have not yet been approved, but we are, that's why we displayed our national network, that we are working in a tiered network. And that's why we showed the different labs at the different levels in the three, but through the tiered network document has not been approved, but we are working in a tiered network. So the question, is it about approval of a guideline or working in a national tiered network? So we just need to understand so that we know why we are scoring or not. You can't.
So in Nigeria, we say, sorry, some abracadabra putting the cart before the horse, right? So you are implementing, but there's no framework, there's no documented. I remember what we say in lab. If it's not documented, it's not done, right? So we are implementing off of thin air. Again, remember that this is not a fault-finding mission, but essentially for us to get things right and do things in the correct order or in the way that they should be done. So if we're implementing tier strategy, on what basis if our guidelines have not been approved?
I hear you on that, but as we shall discuss, because number 3 says tier-specific diagnostics testing strategies exist but not fully implemented. So what does also that mean? So that's where we need to agree, because even taking us to level 3, we don't. It's not fitting there.
I would say you're on level 3.
But not
your
fully
tier,
implemented?
yes, not fully implemented for various reasons. Number one, your guidelines have not been approved. So you can't even fully implement without your guidelines. Okay. The other bit is there has been no mention in any of your presentations around, your strategic documents for lab systems. Many of them have not been updated in a long time. The lab policies. So all of this will probably come up in when we frame your priority actions, but they do add to the body of evidence for whatever scores you have. So if number one, you don't have an updated lab policy that speaks to most of these things, your guidelines for tiered testing have not been approved. So you may have strategies for tiered testing existing, because yes, they exist. But whether they are fully implemented, I would say no. And that's why I would say you're on score 3.
And maybe just to add as well, we are not trying to push you where you don't belong, and we are not also trying to take you where we just want to see ourselves comfortable in a certain area. We are doing something is happening, right? But again, now when we come to the documentation or the legality of doing it, do we have those documents in hand? Yes, we have them in draft, and whatever is in a draft form, we cannot consider it as is something that exists on hand. And just to give you an example, very recently, if you read on the media, there was a self-claimed lawyer in Kenya who won 36 cases, but he has no document. He's not a lawyer. Okay, but he won all the cases that he compete against. So doing something, but we don't have a documentation that yes, we are supposed to do it. It doesn't mean that we are implementing it fully in such a situation. So it's for us, as Dr. Shikanga said earlier, is let's try to look at, are we really doing what is good for our country? Because at the end of the day, if Uganda is good, I believe the neighbors of Uganda will also benefit from what capacities exist here. Thank you.
Yeah, thank you so much. And we are not also trying to be where we are not, but my issue was about if you go a step lower or 2 and read the statements, they still do not fit. So that's where I was coming from. It's not I'm arguing that I need to have the scores, because I know what we go through when we are audited with evidence, but there are some statements when you go lower that do not even fit with what, and that's where the discussion has been. Not that we try to get scores that we don't have. So that's the question. For example, the previous one.
So do we
that's
agree
where
on
we
score
need to
3?
agree.
Do we agree on
So-
score 3?
Chair,
Yes, that's-
We
Chair,
agree on 3.
That's fine.
there is a hand online.
Oh, we have an online group.
Yeah.
Oh boy. Okay.
Morgan.
Okay.
Morgan Otita, the chair has permitted you to speak.
If Morgan is not speaking, I'm afraid we'll have to move on.
Okay.
In the interest of time, yes. So, country, we agreed on 3. On score 3? It's fine. So we agreed on score 3 for that indicator. And we would have a side and come back tomorrow morning and tell the House what we have agreed on for indicators 2 and 3. Thank you. And as well as the priority actions. External, are we okay? External team. Okay. Okay.
Okay. Okay. Another thing with these indicators, the status that we are in is the status that we have achieved. Not the one that you are working towards achieving. So you find that these other trees, there's still some things we are doing to achieve them. We are not yet there. That's why I was pushing downwards. But I'm not sure. I'm not sure if I'm correct. But I think that's it. It has to be fully achieved for you to go past that stage.
And as my team lead is coming in, I think also for the technical team from the country, when we look also at our priority actions, we might need to look at them and coin them so that they are actionable, because even the action verb that we put there might not give us exactly what are we intending to do in the long run. So we shall have side discussions so that we inform them. Dr. Shikanga.
Yeah, and my sister, thank you so much, because you seem to be acknowledging something. That what we seem to be pointing out at level 4, the same weakness exists at level 3, and the same weakness might exist at level 2. And this is precisely what I said in the morning. Let us not massage the tool to fit our desire out of lack of a better way to put it. If the tool points you to level 1, go to bed and sleep. Don't deny yourself sleep over that. It is not your fault. One purpose of JEE is to help us to move all the levels of the equalizer at the same level. Don't push one attribute at a level high up and the other attributes that are supposed to jointly contribute to health security are not developing. And that's why Kelvin is saying, if one attribute at that level is not met, don't deny yourself sleep. Accept that it is not met and let us drift back to the lowest level that we meet all the attributes at that level. It's not you. It is not your team. It is a system. It is a structure. And then we develop the system robustly as we come up. All right. When we suggested we bring lab forward, Dr. Makumbi, we knew, because laboratory surveillance seems easy, but you will see the kinds of things that are going to come up. This is expected. But we are happy with the outcome, and we are happy with the country team.
Thank you so much. So, our subject matter experts, we want to recommend to you for the lab, seeing is believing. So please hold on the score and then you visit the lab. You might even give 5. Thank you very much. To zoonosis. Who are the presenters?
I'm introducing on behalf of Dr. Makumbi, the team that is presenting for zoonotic diseases. We have a Dr. David Mwanguzi from the Veterinary Public Health Division within Ministry of Health. Dr. Opolot John, also from the Veterinary Division, Ministry of Health, the Assistant Commissioner overseeing that division. Then we have from Ministry of Agriculture, Animal Industry and Fisheries, Dr. Monje Fred, and from the Ministry of Water and Environment, Dadino. Please move forward. And I hand over to Dr. Shikanga.
Thank you so much. And one thing I have to really thank you. This time round, you've mentioned those names and where they're coming from. We can clearly see the One Health outlook of that team. We so much desire that. That is not just one sector that's coming to push for a position, but we are all our interests are represented. So from the SMEs for zoonotics, may I introduce Andrew and once again, Fayesa.
Thank you very much. I've already been introduced, so I wouldn't love to spend a lot of time. But I'm also glad that some of the people on the team, we have interacted on a number of occasions in the regional meetings of the East African community. So you're welcome to Uganda. I'm here to present on zoonotic diseases. Probably I think we need to just move and so that is the team. It has already been introduced. I wouldn't really like to waste a lot of time on that. These are some of the abbreviations that you'll actually find in our presentation. So just to give a background information on our technical area is that zoonotic diseases are those that are transmissible between humans and animals, and that over 60% of human pathogens and about 3 out of 5 diseases that are happening every year that occur are zoonotic. Then we're also aware that they constitute 75% of the emerging and re-emerging infectious diseases, and that they require multi-sectoral and multidisciplinary approach for control. And here in Uganda, we have the following key actors in the management and control of zoonotic diseases: Ministry of Health, Agriculture, Water, Uganda Wildlife, academia, implementing partners, the private sector, plus civil society. So our target here, we are looking at functional multi-sectoral, multidisciplinary mechanisms, policies, systems, and practices in place to minimize the transmission of zoonotic diseases from animal to human populations. So we had 3 indicators for this technical area, namely surveillance of zoonotic diseases, then response to zoonotic diseases, and then sanitary conditions. So looking at the strengths that we have as far as surveillance of zoonosis is concerned, one is that we have initiated a process of updating legal frameworks and formulation of the One Health policy. And the best practice is that we have incorporated aspects of One Health and the 7 priority zoonotic diseases. So we are in the process of making the regulatory impact assessment, and we are doing this in a multidisciplinary and multi-sectoral manner. The existence of structures that have already been talked about, like the National One Health Platform, the National Task Force, the Public Health Emergency Operation Centers. When we talk about the public, we mean the national and the regional, which we are calling REOCs. We also have a coordinating center for the control of trypanosomiasis in Uganda. So the best practices we're having here is that we are still using a multi-sectoral approach, like the NTF. It is multi-sectoral, multidisciplinary. Actually, when we have zoonotic diseases, we can have alternate chairs, having the Director of Animal Resources chairing the National Task Force. We also have regular meetings coordinated by the One Health Secretariat, coordinating development plans, P&R plans, and also we are also establishing the regional FIOCs, such that we actually take services near to the people. The regional FIOCs are closer than the national level, so where we feel that the national staff is trained, we can actually build on the existence of the regional public health emergency operations centers. Then we're also decentralizing One Health at subnational level. This one has already been alluded to by the previous presenters. Then we have a list of priority zoonotic diseases, and these were jointly agreed upon by all key sectors. And our plans and strategies are based on this list. And we're also having multi-sectoral response to public health emergencies, especially those that are zoonotic in nature. Still under surveillance of zoonotic diseases, we have developed electronic surveillance tools that are available in both human and animal sectors. Of course, this is to facilitate faster reporting. And we also, the practice is that we are disseminating these tools widely. And the third generation of IDSR that we have rolled almost over 90% of the country has aspects of One Health. And when we are doing the trainings, we involve the other sectors that are key as far as the IHR is concerned. The animal health sector, the environment, the rest. The skilled human resources in both human and animal health sectors, we are conducting continuous trainings. We have the fellowship programs in both animal and human. We have the field epidemiology training program. This one actually is being taken down by conducting the intermediate. We have the one at the national level, then we also have intermediates that is targeting district or subnational level staff. But even on the animal side, we have what we are calling ISAVET. It's an applied continuous training for field veterinarians that builds on the capacity that we have as far as the human resource is concerned. So we're also building capacity of national level public health and animal health laboratories. This one has already been talked about by the previous presenters, especially for lab. Then we have that hub system. I think we have been dwelling so much on the transport network of samples. So we have a shared specimen transport and referral system where we are leveraging on each other's strength, especially the health sector. The health sector was operating the hub system, but now even the animal sector can actually have their samples transmitted to a central place. Then from there, they are taken to the different labs, the animal lab and the human lab. Availability of partner support. We also have a functional veterinary public health division. The commissioner is part of the team there, the assistant commissioner. In MOH and functional department of animal health and public health division in MAIF. That is one of the core functions actually they're handling is the issue of zoonotic diseases. Still on surveillance, we are looking at areas that need strengthening. Of course, the challenge is that, of course, we are using different surveillance systems, namely the IDSR, the MI, ARIS, and others. So we want to operationalize data sharing, the existing MOU. We have an MOU, a Memorandum of Understanding, that was actually the basis, that was the foundation for us to establish the National One Health Platform between the key sector ministries. So in that Memorandum of Understanding for the National One Health Platform, we have got data sharing mechanisms and agreements that we just actually need to ensure that we implement. Then the other area that needs is enhanced reporting rates through active and passive surveillance. Then conduct regular multi-sector risk assessments. The other challenge that we have is that we don't have a designated data person per station in the animal health sector. So issues of data management still have a challenge as far as the subnational, especially district level, is concerned. So the area that needs strengthening there is to recruit a biostatistician in the animal health sector at district and national level, but also train existing district veterinary staff in reporting and data management as a stopgap measure, where we may not be able to recruit the biostatistician in the animal health. We can actually try to orient the existing staff as far as data management is. But as I've already mentioned, that is a stopgap measure. Priority areas for action: fast track the process of formulation of the National One Health Policy, because the Memorandum of Understanding is a loose agreement. So we need to ensure that there is something that binds us to actually really strengthen the coordination, collaboration, the communication and capacity building between the sectors that are actually fronting One Health. Establishment of sentinel surveillance sites for zoonotic disease events in hotspot districts, and we integrate them within the National Integrated Sentinel Surveillance System. The technical area for surveillance is going to talk about the NIS, the National Integrated Surveillance System. But we feel that we need to establish these sentinel surveillance sites. Most of the priority zoonotic diseases are actually occurring in the cattle corridor. So we feel that these are some of the areas where we actually need to have those sentinel surveillance. Operationalize data sharing agreements in the MOU of the National One Health Platform. But also we are looking at fast-tracking the process of development of an interconnected and interoperable surveillance system for all One Health sectors. They should be able to communicate to each other, and we know what is happening across sectors. Then the recruitment of biostations in the animal health sector at district, actually even at the national level, they don't have. So this is how we scored ourselves. We are saying that we are at level 3, coordination of surveillance. I'm sorry, my eyes, much as I have 4 of them, I think the color is not friendly. Same thing. Coordination of surveillance activities of listed priority emerging and endemic zoonotic diseases is formalized between the animal health, public health, and environmental sectors at the national level, ensuring exchange of information and joint assessment of risks using a One Health approach. Sorry. So these are some of the supporting documents, the references that we shall actually present. I wouldn't really love to waste a lot of time going through because we shall present them, I think, in the side meeting for the technical area. So responding to zoonotic diseases, that is the other indicator that we have under zoonoses. The strengths we have are existence of the robust coordination mechanism, functional national and regional FIOCs, they are there. Then what we are doing, the best practice is training of multi-sectoral teams to indulge, to even include such capacity. 2, the existence of functional NTF, the National Task Force for Strategic Oversight, and District Task Force for Operational Oversight. The District Task Force at the subnational level and the National Task Force, especially when there are emergencies that we are supposed to respond to. So the other thing is involving the affected communities and their leadership, like when we deal with the village health teams and even engaging the communities when we are responding to emergencies. Then the existence of functional and readily deployable multi-sectoral rapid response team. At the national level, we have the National Rapid Response Team. At the local level, we have the District Rapid Response. These ones can actually be called upon whenever there is need to respond, even beyond midnight or even at night, 24/7, they're always available. So we have a pool that we have trained over the last almost 10 years. But still, we are doing continuous training as a best practice and orientation and mentorship. Then availability of case investigation tools, SOPs, and reporting tools. And many of these we are digitalizing to ensure that there is faster. We are moving away from the paper-based to ensure that they're electronic. Then we talked about the availability of partner support. Of course, we are always involved. They are involved in preparedness, response planning, and monitoring from national subnational. They're always with us whenever there is need to respond. Challenges, areas that need strengthening, increase the number of RRTs beyond the human health sector. Of course, as we are rolling out the IDSR, because in Uganda, we are using the IDSR to push the agenda of the IHR. The IDSR is the vehicle for IHR. So as we are rolling out, we recognize the fact that we need to even have more. We are having people from the other sectors, but we need to have more increase on the number of those from the other non-Ministry of Health sectors. 2, delayed access to emergency funding. This one has already been talked to by, I think, people who are dealing with financing. We are saying that establish a joint, readily accessible resource mechanism for joint investigation and response. Then the low motivation of rapid responders, develop an updated National One Health Strategic Plan for 2024-2029. But priority areas for action, capacity building beyond human health. We need to increase the number of the other non-public health actors into the capacity building, IDSR and the rest. Establish a joint readily accessible resource mechanism for joint investigation and response, but also develop a new National One Health Strategic Plan, because the one we are having is I think is ending. So this is how we scored ourselves. We think we're at level 3. We think we have a multi-sectoral mechanism for coordinated response to outbreaks of endemic, emerging or emerging zoonotic diseases in place for the human health, animal health, and environmental sectors. So these are some of the supporting documents, but as I earlier said, I may not actually need to go through all of them because I don't know whether participants feel that I should go through one by one. Is it necessary? No, it's not. Okay. So this is a new indicator that was not there in the previous JEE. It's about sanitary and animal production practices. We are looking at the strengths that trained veterinary inspectors to conduct inspection of animals, their products, and their biologicals to ensure sanitary compliance. And we are saying that some of the best practices that we have extended this kind of inspection to the points of entry. We have availability of legal instruments, these ones we shall provide. Then the existence of designated infrastructure for slaughter and inspection of animal and animal products. I think some of these the team may be able to see during their visits. Then availability of animal movement tracking mechanisms. Of course, the best practice here is we are using issuance of livestock movement permits. We can trace the animal right from the abattoir to where it came from. Then fisheries sector is compliant to international standards. This is actually through conducting regular audits and patrols. And because we are compliant, that's why we are still exporting fish to the European Union. Still under sanitary, areas which need strengthening, integrate disease surveillance to include animals and animal products inspection. Because we believe that, for instance, at abattoirs are sites for surveillance, and this information should actually be fed into the routine surveillance data. So the challenges of limited collaboration between vets and health inspectors and clarity of roles. Of course, we have a set of other inspectors that I think we are usually having, but this is something that we can sort out. What is the vet supposed to do? Because the vet's role at the slaughter place goes beyond just meat inspection, but it's also a surveillance function. So increased human resources for inspection and certification of animal products to also cover rural areas and more border points. We realize that in the rural areas, the inspectors are not enough. We also look at fast-track livestock and livestock products identification and traceability system, because we realize that there is limited livestock and livestock products identification and traceability. We are talking about the traceability system we have in place is about animals coming for slaughter, because you can get the movement permit and you go back and you see where the animal came from up to the village and maybe the farm. But when it comes to animal products, it becomes a little bit hard. So we say we need to fast-track livestock and livestock productives in general, other than just looking at the live animals that actually come from the abattoir. Maybe even breeding animals can also be traced back using a movement permit, but how about the products? Then fast-track the animal disease health bill by June 2024. So these are our scores. We believe that we are at level 3. Which says that a national plan for good practices in animal breeding and production of animal products, including sanitary practices, is established on the basis of international standards and implemented. National guidelines for good production practices are developed, published, disseminated, and set for implementation from the local farm to the level of trade in animal products, limiting the transmission of zoonotic diseases. Thank you very much.
Oh, thank you very much for that presentation. I think they deserve a better clap than that one. So I think without wasting time, this should be one of the strongest technical areas for the team here, considering the number of outbreaks they have, the number of endemic diseases. I think we should just go straight to the scolding. You can sit here, we'll not eat you. All right, so let's go straight to the scoring for P51. So the team has scored itself at 3. So coordination of surveillance activities for listed priority emerging and endemic zoonotic diseases is formalized between the animal health, public health, and environmental sectors at the national level. ensuring exchange of information and joint assessment of risks using a One Health approach. Is anybody contending with that? So my only contention with that is that this says there's exchange of information, but according to the points they have raised, they have not formalized the exchange of information between the sectors. So that to me is a gap, unless they can be able to explain how they overcome this and what system is in place.
Thank you very much. My colleague wants to take on that. Dr. Monje.
Thank you very much, Chair. Looking at the scoring of 3, we have actually formalized the exchange of data. And one of the mechanisms we've put up as a country is the establishment of the National One Health platform. Now, if you look at that platform, we have documents which guide us on how to share the information, one of which is the MOU. It details what kind of information each sector should share. The only challenge is the implementation issue, but formalizing it, we've done it by having such a document. Thank you.
Maybe it's just grammar, but in your priority areas of actions, point number 3 is operationalize data sharing agreements in the MOU of the National One Health platform.
Thank you. It apart from just having the document, we've taken in steps to ensure that we share relevant information, especially during outbreaks. What only lacks is that this is mainly among 4, like Ministry of Agriculture, Health, Environment, and then WUA, but we need to bring on board other sectors for more information. And that's why we say we have that. But in addition to that, we have another mechanism through which we share information, that is the National Task Force, which is provided for in our disaster policies provided for. So in addition to that, we also have a center for coordinating, it is COC2, Coordinating Center for Trypanosomiasis in Uganda. That one deals with only trypanosomiasis, but it also helps us to share information which is about, which is cross-cutting as well. Fourthly, was also an initiative to ensure that cross-cutting issues which go beyond Ministry of Health are shared with the relevant sectors like Ministry of Agriculture, like UA. So having such mechanisms help us to share data, especially about zoonoses and other cross-cutting issues like antimicrobial resistance, food safety. So that's why I believe we are at 3. Thank you.
So do I give you the opportunity to change the language from operationalization to something else?
We shall change the language. But one of the issues that I think was causing us some discomfort, when you say formalization and operationalization, it is the issue of English. If the formal, the groundwork exists through which you can share information, but maybe when you have not shared it, I don't know whether you can say that it's not formal. Because the foundation for sharing information has been set. It is there, the documents are there. So, but we can still change the language upon your advice.
One of the multi-sectoral coordination mechanism based on the One Health approaches, data and information exchange and the sharing system. That is obvious. We don't have system, we don't have interoperable system, we don't have officially data and information sharing agreement between those sectors. When it says formalized between animal health, public health, and environmental sector, it's kind of formal agreement for the health issues within the interface of animal, human, and environment, whether there is a formal agreement between this sector or not. So, and if you show evidence of data sharing agreement between sector, and the formal and agreement, that is okay. Otherwise, we need to discuss more.
Is there a formal agreement? That was a question from my co-presenter.
Thank you. I hope I was clear enough. I said the formal agreement which we have is called the Memorandum of Understanding. And this one, if you look at, okay, it's a document which is fully signed by all the sectors, and it details what kind of data each sector is supposed to share. So that's the formal agreement which we have, and it is operational. Thank you.
Actually, we need to move to the establishment of sustainable One Health coordination platform. And for instance, like we have established in Ethiopia, we have already established the One Health Secretariat, and which is more sustainable. And all countries have the memorandum of understanding between the key One Health sector. When we say key, with the denominator health, animal health, public health, environmental health, and also including the wildlife. So we are saying particularly in the coordination of surveillance activities. This is special kind of agreement because each sector has mandated for its own data, and the sharing of this data across sector between sectors requires special and formal agreement between sectors, so that we can have and we don't have difficulties to get those information. That is the difficulties that is existing.
Add on that, one of the things we've demonstrated to show that we are coordinating, that we, after establishing that document, we've so far conducted joint risk assessments together for a number of zoonotic diseases, and you have reports to that effect. We have, whenever we get like regional alerts regarding particular diseases, still we go out together to look out for these diseases. So that is still a real demonstration that we are practicing what we agreed upon the document. Much as the data may come to one sector, but it ends up being shared with other sectors so that they can take action. The data can be related to environment, the data can be related to animal health, but as long as it's going to help other sectors better prepare for early detection and response to diseases, then it is shared with other sectors such that they do it as soon as possible. And that has been possible because of the establishment of these documents, which help us do that. Thank you.
Maybe on top of that, like the colleague was asking, we have a national One Health platform with the staff, with the secretariat, and it's housed in the Ministry of Health, very functional. So that is where all those documents is talking about are stored and housed. All the coordination about response planning, meetings, what there is programming, it's always done by the National One Health platform with even a coordinator, substantial appointed. So we have all that. Thank you.
All right, thank you very much. Maybe I'll throw it to the audience. Is there anybody with a comment from the audience? Yes, we have 2 points. Please, the one with the mic.
So for me, I will just use the same tone like in the previous technical area. You have used very particular words on 2 different slides in your presentation. Why do you find it easier to revise the presentation rather than address? They say what comes out of your mouth first is reality. After thinking, what comes out of your mouth later is thought and massaged by the brain. Would you feel comfortable to revise the same presentation which you gave to us and we have had it, which conveyed the product of your engagement? Or will you want to acknowledge that what is in the presentation is reality, and therefore you better revise the score rather than revise your presentation?
Okay, thank you very much. Yeah, I've been listening and oh, this one. So if we look at 3, the priority diseases are listed, and I think I had some talk about a memorandum of understanding, which is something that formalizes engagement between different parties. So that's between animal health, public health, and environment sectors at national level. And this memorandum ensures that there is exchange of information, then ahead of some joint risk assessment that was done using the One Health approach. So I think 3 is fine.
So I think we are all comfortable with 3, and we can move to the next technical area, 5.2. So for 5.2, which is responding to zoonotic diseases, the team has weighed itself to level 3, which needs a multi-sectoral mechanism for coordinated response to outbreaks of endemic, emerging or re-emerging zoonotic diseases is in place for the human health, animal health, and environmental sectors. So that's level 3. When I look at level 2, it talks about contingency plans for the various zoonotic and epidemic diseases. Are these in place?
Yes, sir.
Yeah, we have them. They're in place.
They're in place, and you can demonstrate that?
Yeah, we shall present them.
All right,
we have evidence to that effect.
All right.
Point 2. I don't know whether this one is a different tool, and the level 4 and the 3. Here with the new tool is different. You know, this is level 4. Level 4 says, level 3 says, level 4 says, multi-sectoral. I think this is a different, yeah, a different indicator, a different tool.
All right, so we don't seem to have a lot of disagreement, but I'll throw it to the audience. Anybody with a comment before we make a decision on the score? No, so we settle with score number 3 for P5.2. P5.3, the score is 3, which reads, a national plan for good practices in animal breeding and production of animal products, including sanitary practices, is established on the basis of international standards and implemented. National guidelines for good production practices are developed, published, disseminated, and adjusted for implementation from the local farm to the level of trade in animal products, limiting the transmission of zoonotic diseases. So that's what leads in level 3. So there should be a national plan for good practices in animal breeding and production of animal products, including sanitary practices. Are these in place? Do we have a national plan for good practices in animal breeding and production of animal products, including sanitary practices? And how far has it been implemented?
Thank you. We have a number of good practices to demonstrate the good practices in animal breeding and production. And these good practices have been, we have different zonal breeding centers in the whole country, which guide them on how breeding should be done, and then this is eventually, the groups are eventually shared with the communities. Of course, we have standards to that. We shall demonstrate that in terms of documentation. We have that. And, yes, we have evidence. The zonal farms to do that. Two, we have these good practices at each of the zones is frequently like shared with the communities to create impact in the communities on the good breeding practices. And we shall demonstrate that to show the guidelines.
That's okay, but the score is about a national plan. So just not zonal ones, but a national plan developed to international standards on breeding. That's all that the score is asking.
It exists.
It exists. That
Maybe even just add on, the zonal plans do not exist in isolation of the national. They are not detached. Actually, they are embedded within the entire national plan. Otherwise, if each zone had its own plan, then maybe you would find the practices are actually differing. So I think my colleagues from the Ministry of Agriculture will be able to present that in the side meeting.
all right, and it also talks of national guidelines for good production practices. National guidelines, that's the key word.
I've tried to see the document, as you have said. I haven't seen that document in the supporting document, so you should show us that supporting document. Otherwise, there is SPS that is in the draft, and a lot of documents. One is communication strategy is also in draft, and the HR World Organization for Animal Health focal point in Uganda is also draft. I think better to work on those and drafts and found nothing as to the national plan for good practice in animal breeding and the production of animal products. And as this one is a key.
Please respond.
Thank you very much. Regarding the national guidelines for good production practices, we shall avail them in case they're not available in the documentation provided in the presentation. Exactly.
And so we hope you present to us approved documents, because the ones in the draft are actually all draft, which means the national plan hasn't been approved. So I hope you'll give us signed documents to show this.
Yes, Chair. As a country, we have the national breeding policy. It is there in place.
All right, so I think we're done. Yes, questions from the audience?
Thanks. I think there is a word implementation there. They are developed and implemented. Can we for sure say they are implemented? Particularly in some livestock value chains, like poultry in Uganda.
Thank you very much. We are doing a lot of implementation. For example, artificial insemination is one of them. There is embryo transfer, another. And all these, we are like training different cadres such that even the farmer in the deepest community can easily access these high quality breeds at the lowest cost possible. So that is the part of the implementation we're talking about.
Go ahead. There are priority actions per indicator, and we want here priority action for the technical areas. I think you need to rewrite again 3 to 5 priority actions for the zoonotic disease technical areas. Now, some of the best practice are not really, I can see they are not really best practice, and better to consider those areas. Otherwise, the time is up.
Yeah.
Yes, go ahead.
Yes, yeah. Yeah, to prove this, in Uganda, we have the National Animal Genetic and Resource Center and the data bank. So when you go for the site visit, you will see it. It does a lot of work in animal breeding, handles all the breeding, improvements, education of the farmers, artificial insemination, and the rest. It is like an authority in charge of breeding. So the issue of implementation of our breeding as a country is being implemented moreover at a high gear. Thank you very much.
Okay, so we'll leave the team with a score of 3, and then we'll wait for them to avail the necessary documents. So that's it from this team. Just to thank you very much for being attentive, and thanks to the team for their presentation. Thank you very much.
I'm a signal.
Yes, team, and there are actually a number of places where over the last thing we could confirm, including our visit to a random slaughterhouse or slaughter slab on Thursday. So apart from them offering the guidelines, we could cross-check from a number of places their knowledge of the existence and application.
Yes, seeing is believing.
You're right. Over to you, sir.
Thank you. So please, can you bear
All
with
right,
us?
sir.
Only one more, and we go home, or we go to our hotels. One more only. And it is MR, antimicrobial resistance, and they are ready, and itching. So can you introduce them?
Covering the area of AMR, of antimicrobial resistance. They will be led by Dr. Henry Kajumbula from Makerere University, College of Health Sciences. He will also be supported by Dr. Emmanuel Isingoma from Ministry of Agriculture, Animal Industry and Fisheries, by Irene, but Irene, your name is hard. But she is from the International Livestock Research, ILIRI. And finally, Mugerwa Ibrahim from the Central Public Health Laboratories from Ministry of Health. Over to you, Dr. Shikanga, for your team.
Yeah, good to see my old friend Henry. It has been almost 10 years since we last met and moved around East Africa together. So from our side, we are going to have caller. And there is something about these Nigerians. When you see a name, don't think that is the complete name. There could be something hidden, either just hived off to give you the name that you're pronouncing, or something else quite twisted. So he is caller, but he is not caller. So it's upon you. Then, yeah, so it's caller and Andrew. Yes, please. Thank you.
Yes, good evening, everyone. I know that the time is tricky for everyone. As the MR team, we are honored to present, and we've tried to be quite candid in our self-assessment. So antimicrobial resistance, as we know, is a big problem in Uganda. Up to 70% of our gram-negative rods in the national referral hospitals are resistant to third-generation cephalosporins. Sometimes resistance amongst Acinetobacter exceeds 70%, and so it's a big challenge. The drivers of resistance abound in the country, so we developed a national action plan against AMR, which was launched in 2018 and is actually expiring soon. So the plan's objectives are to promote public awareness and understanding of AMR, of antimicrobial resistance, improve infection prevention, control and containment in human health, communities, and animal health, optimize the use of antimicrobials in humans and animal health through effective stewardship, strengthening knowledge and evidence through One Health surveillance, and investing in research to inform policy and implementation science. The governance, we have a national framework for coordination of AMR. We have a national One Health platform, and the national One Health platform coordinates activities or promotes collaboration between the various sectors. We have a national subcommittee of the National One Health Committee for specifically for AMR, and each sector is designated to have is a coordination framework for AMR. Then we have a designated coordination framework at the district in the district One Health committees. So we have an AMR subcommittee of that. In the area of multi-sectoral coordination, the strength is that we have a One Health framework and a One Health strategic plan. We have an AMR national action plan in place. We have an AMR technical work. We have an AMR technical working committees. We have existing governance structures at central and local level, and we have partnerships. So we work very collaboratively with various partners. The best practices is that, well, our national action plan was really a One Health effort and very consultative. And one of the other areas has been collaboration with multiple stakeholders. We've been holding conferences and symposia to share experiences and promote awareness and for advocacy. So the key challenges are, while the framework has been alluded to, has been stated, it has challenges. The National One Health platform is not very well institutionalized. The One Health policy is yet to be approved. And in some ministries, the coordination points are not very well established. Reporting in the area of reporting and accountability, is not adequate. Then the National Action Plan is due to expire, and there isn't yet a clear roadmap for its revision. In the area of yes, there is also the need to the monitoring and evaluation framework is still rather weak. So in the areas that need to be, well, again, so I think these have already been alluded to in the area of coordination. And then there is the issue of inadequate human resources to actually coordinate and run issues related to AMR. And then issues of financing. There is no dedicated budget line for AMR activities in most of the MDAs. So in the area of coordination, we scored ourselves 2. So that reads the multi-sectoral national AMR action plan under development. There's a developed plan, all right? Multi-sectoral coordination mechanism has been established with governance and leadership, yes. Well, while we have a well-developed plan, we did not score ourselves under level 3 because the multi-coordination system, the regularity of the meetings was a challenge, so we did not score 3. So the next is multi-sectoral. The priority areas for multi-sectoral coordination. Well, here I listed various priority areas. I think we've been advised that these should be compressed and put at the end, but the issues of coordination essentially need to be strengthened. And then human resources for coordination need to be appointed and appropriately deployed. And then subnational responsibilities of coordination also need to be defined and focal points of AMR recruited. So in the area of surveillance, the strength that we have designated AMR surveillance sites. This is surveillance in the human sector, I think. Yeah, should be in the human sector. Designated AMR sites have been, AMR surveillance sites have been designated. There is a national coordination center and national reference laboratories. Lab testing capacity is available. Guidelines on AMR surveillance. There are guidelines and a national AMR surveillance plan. And there is strong partnerships between government and various partners. And we have trained and competent personnel. Some of the best practices that we are reporting regularly, AMR data to GLASS, AMR and antimicrobial use data to GLASS. And we use the data for advocacy and awareness. Some published some papers related to the data. And there is a strong collaboration with academia and various implementing partners. And we've been regularly participating in tracks assessments. The areas that need strengthening, data management. Data management and data sharing are not adequate. In-country data sharing needs to be strengthened. Data utilization at the facilities where it's generated is not adequate. And then in the area of there's laboratory capacity for all sectors also needs to be strengthened. There is under prioritization of microbiology testing, particularly as far as in the area of surveillance. Then the lab supply chain, the budget line is limited, and while it is the supply chain is well established for the Ministry of Health, it is not as well established for the other sectors. Diagnostic stewardship is relatively weak, and with not adequate skills in utilization of microbiology services by the various healthcare workers. Antimicrobial use surveillance takes place, but it is not in all, it's in a limited range of facilities. It is in some of the regional referral hospitals, and we think that it needs to be scaled up. In that area, we assigned ourselves level 2, multi-sectoral national AMR action plan, level 3, AMR data are collected nationally for common pathogens, but national coordination and standardization are lacking. We couldn't go to level 4 because that requires a standardized national system for data collection with a well-established network of surveillance, designated national reference lab, and producing regular reports. We have the system is well-established, a coordination center, a reference lab, but we don't yet produce regular reports, okay? So we need to strengthen the lab data management through rolling out the lab information systems and strengthen diagnostic stewardship in that area. So as far as multi-drug resistant organisms, prevention of MDROs is concerned, where we have the capacity to detect the multi-drug resistant organisms at regional and national level. We have an existing surveillance system across various sectors, and we have laboratories with genomics capacities. And we report the multi-drug resistant organisms in our GLASS system. However, we do not have the multi-drug resistant, we've not yet developed the guidelines for multi-drug resistant organisms. There is no priority list. And so surveillance detects the multi-drug resistant organisms, but no special attention. There is no guideline to specifically spell out the issues of the multi-drug resistant organisms. So yes, and then the genomics, well, we have the genomics capacity, but it's not really yet part of the AMR surveillance system. So in that area, we are at level 1. So prevention of the recommendations, so updating the surveillance plan to capture the MDROs and put in place an MDRO notification system and capture it under genomic surveillance. In the area of optimal use of antimicrobials in human health, our guidelines have been updated and they capture issues of antimicrobials, our clinical guidelines. There is a national committee for selection of appropriate antimicrobials. We have national consumption data and use data. And then we have SOPs for developing antibiograms. And then we have a prescription book for tracking antibiotic dispensing in pharmacies and drug shops. And then we are able to monitor stock status of the antimicrobials. So areas that need strengthening, the essential medicines list. While we have updated our essential medicines lists, and it actually considers issues of antimicrobials, it does not categorically classify them according to the AWARE classifications. The clinical guidelines, well, considered issues of antimicrobials, but they did not really go in depth of getting consensus on updating issues of antimicrobial use, which are giving guidelines on antimicrobial use. Stewardship activities at the facilities need to be strengthened, and the regulation of antibiotic use is not fully, while the structures and systems are in place, enforcement is still very weak. Optimal use of medicines in animal health, I think I've mentioned some of the recommendations. So In animal health, it was scored at level, in human health, it was scored at level 2. Optimal use of medicines in animal health, strength, there is a vet drug policy, there is the national drug policy, which covers both on humans and animals and covers issues of antimicrobial use on farms. There's guidelines for infection prevention and control and appropriate use of antibiotics for cattle, sheep, goats, and poultry have been developed and disseminated. Surveillance plan and protocols and tools for antimicrobial use in animals. Actually, antimicrobial consumptions is regularly reported. Consumption data is regularly collected and reported. Agrochemicals board, there's an agrochemicals board to regulate use of agrochemicals, and there's a task force on veterinary drugs and agrochemicals regulation, and there's an essential vet medicines list. So as far as strength are concerned, collection of data on use of the data on use of antimicrobials on farms needs to be strengthened. There's currently inadequate funding to support that. There's a need to create awareness on appropriate use of veterinary drugs, which are often misused in the community. There's a need to strengthen the regulation of vet drugs. And then there is a need for treatment guidelines. So guidelines particularly are absent for animals and aquaculture. And there is the need to regulate use of antimicrobials in feeds. Though there is a policy that has been developed, implementation is still relatively weak. So I think I gave the recommendations as I went about. So this was scored at 3, and that level says AMR data are collected nationally for common pathogens, but national coordination and standardization are lacking. So that's the level as far as use of animal of antimicrobials in animals is concerned. So I think those are the issues. As far as the current scores are concerned, the structure of this has changed significantly since the last assessment. But in areas where the indicators are still the same, there has been some improvement in the areas of resistance detection and surveillance. But in areas of multi-sectoral coordination, well, that's a new area. Those are the scores. The lower half of the table shows the new areas, and that's what we are scoring in the new areas. So I think that is it, and these are the members that participated. Thank you.
I want to specially thank you for the time taken for this highly informative presentation. And I understand the structure better now, seminar in Uganda. However, I would like to seek clarification on some certain areas which clear to. So I would like to start with the first indicator, which has to do with effective multi-sectoral coordination on AMR National Action Plan. So if God will, God will. The first indicator, yes. So you call yourself 2, that's level 2, which is a limited capacity with a national EMR action plan under development, of course. You have it in place, maybe just 2.0. So that is okay. Then the second part is a multi-sector coordination mechanism has been established leadership. So which says no multi-sectoral national plan in place. Of course, you have a plan in place. However, to level 1 because of the fact that you have that in place. But if you look at level 2, the second part which says multi-sectoral coordination mechanism has been established. So as we proceed with this discussion, I want us to have it at the back of our mind that we should look at AMR within the context of One Earth approach. Now, when you speak about AMR, is One Earth, no doubt. You might even bring other sectors. This establishment of the multi-sectoral coordination mechanism, which has been established with government leadership. I saw the schema that you presented in terms of the big organogram. Do you have this structure established at all levels? You know, in terms of having an approved structure mechanism for coordination of multi-sectors, you know, for EMR activities. Is it the same? What you have at the national, is it the same as what you have at the district and also at the county level? Because AMR, you know, you spoke about one of the challenges around awareness, curation, and everything, which mostly can be found at the level of the districts and also county level. So do we have a structure, established structure in place across all these levels? That's one. That's the first. Then the second part has to do with at the national level now. Who are the members of this multi-sectoral coordination? You know, in terms of the stakeholders, I'm sure you did a lot of stakeholders analysis mapping before you develop your map. So at the national level, who are the stakeholders involved in this coordination of multi-sectoral activities for EMR? And that's number 2. And the third clarification I'd like to take is that do we have a secretariat within the national level that actually coordinates these multi-sectoral activities, coordination of across different sectors? Because you also mentioned that you had challenges in some ministries in terms of coordinating units for AMR, in some MGAs. So do we have a secretariat coordinating the activities across different sectors at the national level, also at the lower levels? And those are, let me just stop there for now. Like I said, I'm not taking you back to 1 because of the fact that you have a plan in place. You are even in the process of developing the NAP 2.0 because recently I read from one of the supporting documents that you submitted that you just conducted an evaluation of the implementation of NAP 1.0, which is great, and you identified a lot of gaps. So you may respond to some of these. I'm asking those questions just to get more information about this level where you have put yourself, but not to take you back to level 1 because you have a plan in place already.
Thank you very much. As far as the Secretariat for coordination is at the National One Health platform. That is clearly designated as the Secretariat for coordination. So that's a clearly defined secretariat, and it's carrying out responsibilities, albeit some challenges, okay? It may have challenges in resourcing and facilitation of the the National One Health platform, but it is clearly the coordination point, the secretariat. When it comes to who is on the National Coordination Committee, the representation, again, that is clearly defined in our National Strategic Plan, okay? I don't know if someone has access to the National Strategic Plan and get to that point, but I can say we have representatives from Ministry of Agriculture, Animal Industry and Fisheries. We have representatives from Uganda Wildlife Authority, representatives from the Ministry of Health, the academia, the health development partners, what else? Water and environment. So this is civil society. I think it is clearly defined in our national action plan. The other question was about the coordination at sub-national levels. Yes, the structure is laid out, but this has not reached all of the what? It has not reached each and every one of our, how many districts now? 140, this seems, it's a relatively moving target. So 148 districts.
So, okay.
Yeah, thank you very much. Just to add on what my senior colleague has submitted, there's also the sector-specific coordination points. When you go to the WHO GLAS guidelines, you find the NCC, National Coordination Centers. So these are also coordination arms within those sectors to handle the sector-specific AMR peculiar issues. And we have one which is very active in human health and also in MAIF, Ministry of Agriculture, and Water and Environment. They are working. These are NCCs. And then when you go down at the site surveillance implementation site, we are implementing a sentinel surveillance model. You find the medicines and therapeutic committees. That is for human health. Now, the medicines and therapeutic committees are at that level to handle AMR coordination activities, as well as understanding or dealing with patient management, surveillance at site level, as offering leadership. Yes.
But like I said, time on this because we leave you at level 2. However, it's important for you to take note of all those important points so that you can still build more around that level 2 that you are. There are still some activities that you can do to make sure that before you proceed to level 3, that means that you have to review some of your priority actions to expand the coordination scope of level 2. So my co-lead, I would like to call on you if you have any additions to what has been said. Then to any addition, do you have any contrary opinion to what has been said? Any objection? You agree? Thank you. To the audience, colleagues too, do you want to take them back to level 1 or you want to, they should stay at level 2? I'm asking. So I think we are fine. We can move to the next one, and please take note of all those important points that we have raised. But before I move to the second indicator, you said that the coordination mechanism that you have, the structure that you have, like a secretariat, is one platform. I'm not sure if you can really describe one platform as a secretariat. I think it's supposed to be a platform for a change of. Is that the name of that secretariat for the AMR coordination at the national level? Because the platform is supposed to be a kind of medium through which maybe you share information or you communicate. Or is there any name given to that secretariat? Because you need this, for you to have an effective coordination at the national level, you actually need a secretariat, which can be operationalized through that platform you are talking to. Is there any name of any designated structure or institution that has that overall coordination of AMR activities at the national level? Platform is supposed to be like a channel medium to, to operationalize that structure. Is there any name for that institution where AMR coordination is domiciled at the national level? I don't know if my question is clear. A platform should be used as a medium to operationalize that particular secretariat I'm asking for, because it's important for you to have a secretariat if you want to have an effective.
There is a coordination office, a One Health coordination office. Yeah, and that's where the One Health platform sits.
That's fine. So let's move to 4.2, right? Yes. So we agreed that the score is put at 2. So that's fine. For 4.2, you give yourself 3. And I have to really clarify this very well, because for I'll first read level 2. The attribute for level 2, which is AMR data are collected locally for common pathogens in hospitalized and community patients. But data collection may not use a standardized approach and lacks national coordination or quality management. That's for level 2. That means that the data, you actually highlighted some challenges with data collection, data management, data sharing in your presentation. So giving yourself level 3, which says that AMR data are collated nationally for common pathogens, but national coordination and standardization are lacking. So if you look at this, I would like to go straight to the point. There is what we call routine data collection, just like IDSR. It also is applicable to AMR too, whereby on a routine basis, you actually share data from the local level from the subnational to national. That means that you are supposed to have a platform at the subnational level. It might not be too structured, whereby you upload information from the subnational. So that's something that level 3 is talking about. It's supposed to be routine, not adversarial. And that's why you are able to report to GLASS on maybe every 6 months or maybe annually to GLASS. That's the Global Antimicrobial Surveillance System. So do you have this data being routinely collated at the subnational or adversarially collated and sent to you? Is there any structured approach? Because of the challenges that you highlighted in your presentation, that you had issue with data sharing, data management. So if you have issue with that, how do you centrally collate your data? You see, routinely or adversarially? So it will determine, if you're able to answer that, provide clarification to that, it will determine what level we should be. Yes.
Okay, the data is collected and collated routinely. Okay. The issue of sharing is that while the data is collected, it is collated, but there is no mechanism for routine sharing it. And I'm not sure if collation and sharing are really the same thing. The data is collected, the systems, yes, systems are there to analyze and collect that data, but it's not, the mechanisms for sharing it are what are lacking.
Okay. You want to say something? Yes, please.
I just wanted a clarification on the number of surveillance sites that you have for both animal health, human health, and wildlife health. How many surveillance sites are you collecting data from routinely?
Okay, thank you. I'll respond for human health. For human health, and my other colleagues will respond for their respective sectors. For human health, we have designated a national microbiology reference lab. That's a site. And then we have 17 regional referral hospitals, which are designated as sentinel sites. And on top of that, we also have labs, 3 labs in the academia, which offer testing, because these belong to teaching hospital. And one of them is Makerere University, another one is University. Yeah. Those are our designated surveillance sites, which share data with the National Reference Lab. And the National Reference Lab works with the coordination center within the human health to have this data analyzed and then shared with GLASS. I'll ask my colleagues in my.
Thank you.
Currently, we have 7 surveillance sites in animal health, and these ones are constructed around our regional laboratories, veterinary laboratories, and these act as our catchment or sentinel sites. So in each, I think we have several districts where that are attended to or handled by those 7 sites. Yes.
Particular area. So is the situation the same for both for human, animal, and environment sectors in terms of this central collection of data? And again, at what time, if you collect your data on a routine basis, at what time do you get those data? Because it's supposed to be time bound, just like IDSR, for me to consider it as routine. If it's not a facade, what time do you get your data for human, animal, and also for environment health sectors? Otherwise, if it's not routinely collated, then we can say that they are collated haphazardly. If you agree with me, all of you.
Okay, if I have understood your question very well. Routine versus not routine. We have designated sentinel sites which do routine microbiology. And then they work with the reference lab. So after a period, maybe a month, quarterly, they send data to the national for analysis and reporting. That is within the human health. And this data also informs corrective action for training, for capacity, and also informing proper diagnostic stewardship for AMR. That is how the system is designed in human health. I may ask colleagues.
I hope I understood you, because in one way, probably wanted to think that the human health and environment and the animal probably collect data around the same time, right? Or am I wrong?
So if you have a separate structure for human, animal, environment, the most important thing is that even if the data is not coming to the same point, in terms of harmonization, for animal and environment, do you also routinely collect data nationally? You have a platform where they upload
Yeah,
data to.
yes. This data is collected quarterly
Okay.
for animal health, and when it is collected and submitted to the at the national level, have what he talked about as the NCC. When data comes from the various points to the national reference laboratory, then the NCC sits, discusses this data. So there is that point where it converges.
What of environment sector? Because we have to move now. But if you know there are gaps in terms of collection of this data from the subnational, because that's the only thing that can make you stay at 3. If it's the same for all sectors, we can be on 3. But if you think that we still have some specific some gaps to actually address, I think we might stay at 2, whereby we try to improve and move to 3.
Yeah, for just a minute, a second. For environment, different sectors at different levels. So they are just coming up with surveillance strategies, and whatever is happening now would be ad hoc. But we can't say that they're all at the same level, and that's why we scored ourselves at that level.
Thank you so much, and thank you, Prof, and the team for the great presentation. My key question is on the fulfillment of the key indicators on level 2. You described very well what you're doing with the reference with the Sentinel sites. I wanted to ask on the collection of data for common pathogens. in community patients? What do we have in place to fill that indicator? And also, how have we set up surveillance, AMR surveillance for community patients and outpatients? And do we have any reports and all of those pathogens that we are doing surveillance on for the communities? And how are we doing the surveillance? Thank you.
For the communities, it depends at what point the specimen was picked. So when we get, this is lab-based surveillance that we do. So when we get a specimen, we categorize it as whether it is a community specimen, if it is less than 48 hours, I mean, if it is within less than 48 hours from the time of presentation. If it is beyond 48 hours, then we consider it as a hospital acquired, whatever. So that's the basis. Not that we go into the communities, but we receive all the specimens at the healthcare facility.
Thank you. That's the last.
Yes.
Yes.
Okay, thank you. My concern about data collation, when it comes to the national level and when the NCCs are looking at them, we need to have interoperable systems between the three systems like environmental, public health, and that of animal health. So do we have interoperable systems which are in place to make sure all the data collected from any single sites are operationalized and then seen at the same level and necessary actions are taken upon?
So the last one, really for me, I wanted to ask so that I see if you can go to 4. But I see your friends upstairs want to see if you can go to 2. But the question is this: did public health, human health, contribute when you were developing variables for the data that you collect in animal health and environment? Number one. Number two, and also the converse side of it, did you contribute to their variables? You collect your data quarterly, they collect their data monthly. Have you considered, have you had a common sitting where you have thought about harmonizing the frequencies? That's number two. Number three, you collect data. Is that data shared across? And if it is shared across the sectors, can we have any evidence, even if it's an email in August or July, that shows that you shared the data across the sectors? Number four, even if you are doing separate, they are doing separately, are those variables common in such a way that you can be able to collapse this data? Because microorganisms are microorganisms. E. coli is E. coli, be it in, I don't know if they infect dogs or not. But do you have a way of collapsing this data so as to have a complete national picture of this particular vector from animal side and from human side and from it, so that we have a much more complete picture than having half or a third of the picture and leaving out what's happening from the other side? So if we can look at those 4 things, we can conclude if there is a national coordination mechanism or you are still just working separately, in which case we could consider a 3, or probably, if you can't convince him, then deteriorating to a 2.
For that, do you want to respond? And if I may just advise before you respond, from what you have been discussing, I think level 2 might be the most appropriate based on the discussion. However, you can still respond to some of the concerns that you have raised.
Yeah, thank you very much. Yeah, the issues of data sharing and exchange of data, I think we acknowledged that that is still, it's still very weak or hardly there. Okay, so we are not really exchanging and sharing data across the sector, I should say. unless maybe someone active asked for it or something. So currently, there is no mechanism. But maybe one thing to say is that I think we really tried to read this thing, and we tried to be as sincere to ourselves as possible. And from what I read, level 3 says AMR data are collected nationally for common pathogens. That happens. But national coordination and standardization are lacking. So I don't know if what we've described does not exactly say that.
Okay, yes.
Okay, so thank you very much.
So I must appreciate your sincerity and objectivity in your scoring, no doubt. However, when I started, I said something about routine and adversarial data collection, okay, from subnational to the national level, okay? And of course, do that, there's also need for you to ensure integration as a analytics. So you should actually target getting to that level of like ensuring like integration and also timely and routinely collection of those data. I think if you can achieve this, I think you are good to at level 3, right? But for now, may I kindly request that let's stay at level 2 and see what you can do to ensure we both further strengthen the the collation and also the sharing of information across sectors. I said AMR, you can't isolate one particular sector away from other. They go together, right? So it's like when you are raising a child, or twins, you raise them together. You can't leave one behind. Once one is lacking behind, then there's a problem. You can look at it from that context. I think you will agree with me that we should stay at level 2. Is that okay? Thank you for accepting.
But unless we are interpreting this document very differently, well, we don't mind to, but that is not what the document says. But if you feel we
So
should
maybe technical area lead, what I would guide is if you can handle this in a side meeting, and while you're doing, I would just want to underline keywords that are going to be the determining factor. The keywords are in number 2, collected locally, and number 3, collected nationally. So I may request that as much as we regroup, leave this pending, regroup, have a common understanding on what it means to collect locally and what it means to collect nationally. The difference in your positions may be informed by agreement on the use of those two words. Then after that,
thank you.
Yeah.
Thank you very much.
We do that. Can we go to 3? I don't think there's any problem with 3, indicator 3, because they are already at 1, and that's fair enough.
But is it? I'm just wondering: is it to make it as low as possible?
No.
Or to actually place a group where they belong?
So it's to just strengthen the system in a more objective way, right? Just to be on the same page. If you are
Okay.
first,
So, since we are at 1, no problem.
so just ensure that your recommendations,
Maybe
your key
it's possible to move that one according to your assessment to observation to now.
Okay. I think we are going to be on one. Thank you. Can we go to the next one? Thank you. Next, P4.4. Godwin, I have to go and ask for his name so that it will be. Yes. So that's for 4.4. You are at level 2 for this one. National policy and regulations promoting appropriate antimicrobial use and antimicrobial stewardship. Activities are developed for the community and healthcare setting. So do we have this policy? Can we see it? And is it published? So because the first one says no or weak national policy or regulations on appropriate use of availability, quality, and use of antimicrobials in human health. So this one is specific to human health, okay? So if this policy actually exists, I think level 2 is good from my side without much ado. And only for us, it is, can you make this policy available just for us to see for this particular indicator? Is it available?
The National Drug Act. and I think we'll share that.
Okay, that's fine. I think it's also straightforward. I think we can leave it at level 2. And if you agree, colleagues on the iTable, everybody's on the iTable anyway, so we are good to go. Let's go to the last one, which is on second to the last. 4.5. 4.5. Which is on optimal use of antimicrobial medicine in human and animal health and agriculture. And that's 4.5. And you score yourself what now? That's level 3. So
Yes,
I've looked at it and also the supporting documents that you submitted. And let me start with level 1, no policy in place. That means that you have policy in place for both human and animal health and agriculture. Then level is national legislation covers some aspects of national manufacture, imports, marketing authorization, true of safety, quality and efficacy and distribution, antimicrobial products and antimicrobial pesticides. You have that in place. Then you move to level 3, which is national legislation, all aspects of manufacture, imports, marketing authorization, control of safety, quality and efficacy, and distribution of antimicrobial products and antimicrobial pesticides. So do we have this policy that's actually, this legislation that describes all these attributes? Do you have that covers? Just look at everything that we have there on level 3. Do you really have this in place?
Yes, they are present.
So look at all your supporting documents. Is the one on pesticides really? I don't know if you have, if you had come across that before. The legislation on pesticides as a product. Do you? Although if you look at the last phrase before, however, in some countries, because of the fact that they want to have that pesticide companies, so they can say level 2. Level 3, of course, okay, but you might want to reconsider that that is lacking is level 3.
Did you see the document on pesticides?
No, I didn't see any document on pesticides. Is there any document?
No, I think it can be availed. There is something, both veterinary pesticides and crop pesticides.
I will agree with you to stay at level 3. Otherwise, you may want to consider going back to level 2 if any component of this is missing. So, are you going to make available the document on pesticide?
Yeah, we can.
Okay, so we'll wait and collect that for level 3. So, I agree with your key recommendations, priorities, and I think we can still work together to look at that. So, before we finish this session, I would like to call up Colleague to quickly, if he has any other submissions.
Yeah, just one question. I believe there's a Uganda authority, and according to WHO classification from level 1 to 3, where is this authority? Whatever authority regulates human medicines should be classified between level 1 and 3. So where we use the manufacture and all these other controls, if you're level 3, then it allows you to do all this, the manufacture, the market authorization. If you're not at level 3, then we need to discuss.
There is the Drug Policy and Authority Act, which establishes the National Drug Authority.
Question was, the National Drug Authority, at what level of classification is it? Is it at level 1, level 2, level 3?
Unfortunately, I think our pharmacists colleagues are not in the house, but I know that we do issues, it handles issues of matcha, and I think I've read some literature that it is one of the recognized authorities around, so really highly regarded authorities in the region, but we'll need to check and verify with our pharmacist colleagues.
So thank you so much for those clarifications. So I think myself and my colleague, we agree to leave it as it is, level 3. However, you've said that you're going to provide the documents on pesticides so that. Colleagues, do we have any comments, any additions to what you've said? Do you agree that we should leave it at level 3, or we should make it level 4 or 5? So I think I can't see any answer. Thank you. So we agree at level 3. So thank you, colleagues, for your clarifications and for your understanding. So can we appreciate them, please?
Thank you.
So on this note, I will hand over to Dr. Makumbi.
Thank you, team. I think this brings us to the end of the. Please, all those technical areas which they have promised documents, please bring those documents. Otherwise, we shall go to one. Please bring those documents so that the external team can look at them. This area, promise reality. Please don't leave the tea. I see some people going. Take this tea. We have already paid for it. 2, tomorrow, we are going to be an official opening at around midday. I'm saying around, I don't know when the dignitaries will arrive, but around midday. But can start exactly at 9 tomorrow, so that by the time we go through the official opening, we have covered about 3 technical areas. Today, we have not done badly. We have covered, I think, six of them. But please, let's tomorrow, and please use the Entebbe Express way. Then you'll arrive here early. If you take the other one, you will not arrive here early. So please, everybody, take Entebbe Express to access this place, because the other road is being worked on. And then, Dr. Shika, there is something we call caveats. Are those all the things? We used to say, okay, I give you a 2, or caveat this, or contingent on this. That language still holds. But that some of them be, I don't know whether we need to apply on some of those caveats where possible. So please, tomorrow, documents, and let's start exactly at 9 so that we can really finish. I think it's now time for tea and depart at leisure. Thank you very much. This is the end of the day, and thank you very much, our external team. Please give a good one for our external team. Thank you so